Hey, Varshini, are you here? Hey, is Dr. Kirti? You want to do mic check?
I'm just calling Kriti. Yeah.
I saw her join actually.
Right. Okay.
Um, hello, welcome, Smriti.
Hi.
Hello, Smriti.
Hi.
Hi. Hello, that is Dr. Sandhya Smriti.
Okay.
Smriti, my partner. I was telling you that
Yes.
I will
We
be
just
playing hide and seek. Yeah.
yes, we couldn't meet the other day. Yes.
Yeah.
Very nice to meet you, Dr. Sandhya.
She
Nice
just
to
come
meet
down
you.
from Dubai, so she was busy with the travel plans and all that.
I
Yeah.
think at
I
the
see.
right time, this webinar is happening because I'm thinking what to do in Dubai. Maybe I'll have some inspirations from here.
Oh, absolutely. I think this is solved for a lot of such scenarios.
Yes.
Ah, right. Thank you. Welcome to the program. There's also Varshini who's
That's
assisting
actually,
us.
yeah.
Yeah.
Hi, Varshini, and thank you for coordinating and the back and forth that happened. Yeah.
No issues. He's been a big help. So, Smriti, how we would go about, as I said, I'll do a brief welcome and I'll introduce you and then I'll hand over to you. Okay.
Yeah, I think Varshini is going to run the slides
Yeah.
for me.
Yes.
And I
We will help
can
you.
just say
Yes.
this is such a relief not to run your own slides, you know.
So you can let
Yeah.
her know when you want it to be changed.
Move. Yes, I'll say share that.
So, Varshini, can you add people?
I've been admitting since the participants are coming now.
Right.
So
Right.
yeah.
How many do we have? 25. 26.
So for 30, I think. Yeah, 27.
I think Smriti also has some other meeting after this. Yeah. So we'll have to wind up by 8.
Thank you for that.
Yes, definitely. We will also moderate the questions so that it doesn't go beyond 8. Yeah.
Yes.
So it's 7, right? So we have about 30 people. So I think we should start. Yeah. All right. So good evening, participants. It's a big pleasure here to welcome Dr. Smriti, good friend and very nice human, very warm. I know her for a few months, but it's as if we know each other for so many years. So we just clicked, and that was a big part. So thank you, Smriti, for agreeing for doing this program for us, Element Edge. It's also my privilege to say a lot of things about Smriti. So she's one of the first people to talk about tele-mental health. So, she's a big leader there. She's an experienced leader in the field of digital mental health and has carved in the area of ethical delivery of digital mental health interventions. She's been working in this area for more than 10 years, even before the pandemic came in. So I think even before people were even thinking of looking at mental health and tele-counseling. So I think she's kind of, a big leader, way ahead of the times. She's one of the few trained telebehavioral health professionals in Asia, and she's working as a chief psychologist advisor, offering mental health support at the scale via AI, mental health chatbot, and human therapist. Her expertise lies in designing deploying clinically safe digital mental health intervention and ensuring clinical safety and quality of mental health service. She's published a lot of papers and book reviews. She's also given us the guidelines on telemental health in India, and she's been a part of Indian Association of Clinical Psychology and Clinical Psychology Society of India. She also leads the ethics committee health vertical for therapists in tech and EMHIC. So it's a great privilege for us in Element Edge and all of us here listening to you, Smriti, that you are here, taken your time out from your busy schedule and taking us through this. So over to you, Smriti, and welcome to all participants. Yes.
A very warm welcome to everyone, and thank you, Dr. Kirti, for that very humbling intro. And my entry to the field was absolutely by accident, just like Dr. Sandhya was just sharing that she's in a different country and wondering how she can best, make use of her skills. And it's very hard for us to not interact with patients, even if we move away. And it was a couple of years back when I was in the US on a dependent visa. That's a different story. We can talk about woes of being on an H4 visa on another session maybe. But I had to find work for myself. And I tried connecting with my clients on Skype, which was what was really popular back in 2010-11 to connect with family members and other people. But then I once read an article as to how Skype, because it's a third-party server, it is a third-party software we are using. They will use the data that is being transmitted in packets. So maybe not the entire video, or the entire chats or conversation, but bits and pieces of it to improvise their own service. Their intent is not a data breach, but still, there are intimate private conversations that happen between us and our client. And that made me suddenly pause all the work that I had resumed with my Indian clients when I was in the US. That's one way I was trying to keep myself occupied and busy, to just stay connected with my clients who I knew very well. I didn't take any new clients then. And then I looked around for courses, guidelines, and I was very lucky to be inducted in a program run by Dr. Marlene Meho, who's a pioneer in the US in this field, who's been a part of the ATA, the APA guidelines, formation, everything. And she runs courses, and she offered me a space in the scholarship program. And I did a course with her. And I think that's why I have been doing these kind of training programs for some people who may have attended an ISCP Pearson collaboration webinar in 2021. They may find some of it repetitive, because I did it back then as well, to assist our community with the shift that everyone had to forcefully make to the online world. And yeah, I think we can start. And I'm sorry, it's a Saturday evening for many people. I'm stealing away your Saturday, and I hope this 1 hour is worthy of the effort that Element Edge has put in arranging this program. We can move to the next slide, please. Yes. Okay. Yeah, next. Okay, this is something which I always do for all my webinars, in person webinars and trainings, or any other presentations I do. It's again a part of the training that I've received, that we need to state with complete transparency about who we are. And I'm a qualified psychologist and not an attorney, physician, or information technology specialist. So my domain of knowledge remains mental health. And things which I may say here in terms of ethical and legal guidelines, we need to check with which country we are in, with the legal, and if it's in sync with the legal and ethical guidelines there. And there are specialized attorneys who guide with telemedicine, telemental health setups. So I'm not one of those. And the goal of this training is educational only. And whatever I'm presenting is my best attempt to bring you timely and relevant information in a very rapidly evolving era. When I began, it was Skype. Today, I'm working for an AI chatbot company, which wasn't imagined even 7 years back. And you're encouraged to seek specific advice related to your circumstance from your professional body or credentialing authorities. Yeah, next. Okay, the objectives are, and also I understood this from the questions that we had received ahead of time, that we want to understand what is telemental health overall, what kind of services, what do they include, and basically a lot on guidelines for conducting what is online therapy counseling, what are some things we need to keep in mind, a little bit on assessments as well, because we do need to conduct assessments, whether it's to plan for a proper management for our cases, or to just understand where the person is with their emotional or mental health at that point in time, to signpost them or guide them if needed, and to be able to identify legal and ethical challenges that one may face while delivering telemental health services. Next. Okay, just we can spend less time on these a couple of next slides, because we all know, we are from the fraternity and we know the constant conversations around the service provider and the end user gap, that there are about 450 million people globally, and this data is a little old. Definitely pandemic would have given a steep rise in numbers to what I have quoted here. And projections suggest that the health burden due to mental health disorders will increase to 15% by 2020. And this was said by Miran Lopez in 1996, when we hadn't even imagined something like a pandemic happening to us, and all of us being forced into social isolation and quarantined, and the issues that then happened. And in India, 70% of the population lives in rural areas, we know that, and there is limited access to mental health services. And people also have to plan for travel, incur time, financial losses, and these are all barriers to seeking mental health care. Next. And I mean, we all know that we have the population is ever growing. It's almost like a burst happening right now, and 6.5% of India's population lives with serious mental illnesses, and only as many social workers, psychiatrists, and psychologists for every 100,000 individuals exist. And again, this is a little data is a little redundant right now. Maybe we have newer data since then. And most of these mental health professionals are again located in the urban centers. Of course, we all want to be where people are more aware, where the lesser effort goes in setting up practices. It takes a lot to first create awareness, and tier 2, tier 3 cities are really facing the brunt of lack of credentialed and qualified and licensed people in the tier 2, tier 3 cities. And there is a need that is again a gaping hole over there that needs to be bridged. Next. And then there are other factors widening the gap, like we all know about stigma. The referral system, personally, this is a pain point that I have experienced. I don't know how you all feel in the hospital setups that we are all working in. That referral system is such that most cases needing mental health services, especially psychotherapy, don't even reach clinical psychologists or counseling psychologists. There are a lot of other professionals who claim to offer talk therapy along with the medications, and then it just stops there. They are not referred or recommend or signpost individuals to the right professionals. And then, of course, crisis times like what we're experiencing in the pandemic have exacerbated the need and created even wider gaps. But I think the silver lining to what happened because of the pandemic is that people have become more about mental health. They've become more aware about their own mental health concerns. They have seen people, the cases, the individuals who already had mental health concerns, when they couldn't reach their therapists or their providers due to in-person services being stopped. Everybody saw what happened at that point in time. It was almost like a mental health tsunami as well. And that is the reason why there was a forceful shift where quickly setups were made, arrangements were created. A lot of, even in the US and the UK, these countries, they created guidelines very quickly to help bring in the mental health care, which had been paused because of restrictions around meeting providers in their setups, and only emergency services were being allowed that time as in-person services. Next. And this is interesting. This is a advertisement which is from the 18th century at some point in time, where you can still see that, people wanted some way where accessing care, whether it was physical healthcare or mental health care, could be done from one's own bedside or from one's own comfort zone. So eventually, by the time now around, when we are in the nearing 2024, 2021, these years, it had to happen. Whether it had to happen naturally or whether it happened because of a crisis that happened, that shift, everybody had to think about it. It was like, you flood the plains. That was what happened, where everybody really got to thinking about telemental health services. How do I reach my client? How can I support them better? What kind of legal guidelines, ethical guidelines I'll need to follow? Then a lot of guidelines around offering other forms of online therapy, it was initially just limited to video, and then people also started considering text-based therapies and audio-based therapies, starting adapting the existing therapies which were offered in person in a way that they could be delivered in a more effective way, even via online modality. So it had to really happen. Next. And yeah, so like I said, that internet provides opportunities for private instant communication, and telemental health is the bridge between the ever-increasing number of clients vis-a-vis the limited number of mental health professionals. And it can be used to provide psychiatric consultation, psychotherapy, and also train manpower. So when we say telemental health, it is online therapy is only one part. Telemental health is an umbrella term, and it includes everything else that is being use those modalities, whether it's audio calls, whether it's Zoom, whether it's any other modality, to offer group sessions, to offer individual sessions, or to train manpower. And I think NIMHANS has kind of led the way in using online modalities to offer training via NIMHANS Echo. It's a model which other countries are also aiming to follow right now. Yeah, next. And with this background, telepsychology using the World Wide Web has become an increasingly preferred component of mental health service delivery. And even though for us it may seem like it's very recent, it's actually entering its 6th decade and a well-known practice in the medical field. Many other medical fields like physicians or pain professionals or even derma care was already offering services via telemodalities, and even telemental health had actually kind of started blooming much earlier, and this is almost the 6th or the 7th decade now. This is with regards to how it's being offered in the US since past many years. Next. So a couple of terms that are often used when we talk of telemental health or online therapy, if we can be more specific, are telepsychology, which is providing psychotherapy and or other psychological services using technology media that can bridge geographical distance between healthcare providers and patients, such as telephone, email, internet-based communication, and video conferencing. Specifically, online psychotherapy will be the process of interacting with a therapist or a counselor and a client online in ongoing conversations over time, when the client and therapist are in separate or remote locations, and they utilize electronic means to communicate with each other. Next. We can skip this. Next. Okay, and online, now what are the modalities which are being used? Different modalities, it's not limited to video. Online therapy services could be delivered to and received, one in individual and second in group mode. Another characteristic feature is the time of service delivery. When an intervention is delivered in real time, like right now, I am speaking to you in real time, it is called synchronous. And when it is delayed, like emails or text messages, which somebody reads later, it's called asynchronous. And the mode of communication which is used to deliver the online therapy or online counseling, which is text, audio only, or by video. And sometimes, like at Visa, we have a blended model where we offer a mix of video and text. Of course, the rights remain with the client, that whether they want to really switch on the video also in certain sessions or not, because they may not be in the best scenario or situation where they can sometimes turn on the video. So they can choose to just stick to audio, or sometimes when even audio is difficult, they can just start communicating with their therapist using text in real time. Yeah, next. Yeah, I think we've covered this. We can go to the next thing. To think that clients in the new century would not expect to access internet counseling services is probably foolish and short-sighted on our part. And I really, again, appreciate that Element Edge is trying to create that awareness and helping professionals learn more about how telepsychology works, what kind of things to keep in mind for online therapy, to offer it in a legally and ethically safe way. There are many studies which compare clinical outcomes of patient enroll in telemental health programs, example, video conferencing or internet-based therapy, with those being treated as usual in face-to-face setting. And it has demonstrated, the literature since 2003 has demonstrated that telemental health services are satisfactory to improve patient outcomes and are probably cost effective as well. There's a lot of cost in terms of a lot of paperwork, a lot of traveling, setting up an office space. So all those costs on both user or the client and the professional side are managed better. Also, when we talk of positive findings, there were some other findings which came up when these initial researches were being done, which then led to developing of more rigorous guidelines. And these findings were that quality of therapy that may be impacted by technological difficulties like poor audio and video quality. There may be difficulties with forming therapeutic alliance, and I think from my own experience, when I entered into this field, this was the biggest question that I had for myself, that it won't be the same. We've actually studied for various schools of therapy. They believe that the physical room setup is so important to create that entire environment where a person feels safe, they feel heard, and the environment should not be intimidating. And it is an important step that we take when we talk of therapeutic alliance. And how will that environment be created in an online setup, or say in a setup where only text modality is being used and the person cannot even see your face, or they won't be able to gauge so much about you. There will be lack of the body language cues, audiovisual cues. Then another one could be extra hassles like equipment setup and scheduling hassles for providers. And for the user side, there could be hassles around not being very digitally aware, not knowing how to operate different kind of systems, or they will have to be they will need to be a certain amount of digital literacy to be able to be brought into the online therapy space. And also there could be false claims around one's identity or issues with licensure on the provider side. We don't know who they are, because I'm just sitting in one corner of the world offering therapy of the country, offering therapy to somebody sitting in the other part of the country. And I can build my website, I can just put things, but how do we verify that? How do I know if the person I'm speaking to is the person I'm speaking to in terms of their identity? And same goes for the users as well. There have been episodes where people have just come in for online therapy sessions, bringing in medical legal issues, claiming, and they are not the person who they are claiming to be. And that has created certain medical legal concerns as well. Specifically if they were in crisis, or if the provider is not well trained enough to address those issues. Next. Yeah, there is a lot of evidence that supports online therapy, and the evidence is only growing. It can be adapted for many uses, including patient intervention, psychotherapy, assessment and evaluation, psychoeducation and counseling, professional supervision and training. And studies reveal advantages which are increased care access, enhanced efficiency, reduced stigma, ability to bypass diagnosis, specific obstacles to treatment, such as social anxiety or physical challenges or disabilities. It doesn't even have to be a disability. It could be something as somebody, a woman is pregnant and she's experiencing symptoms of depression, but she's been advised bed rest, and how will she go to a setup? Or somebody who has any other physical challenges that prevents them, elderly people, So these are all barriers which make people reconsider, should I go, should I not go? It affects their motivation, etc. But online therapy has increase their access, has removed those barriers. Next. There are different kind of clinical disorders that have been treated efficaciously via online therapy: panic disorder, phobias, obsessive compulsive disorders, post-traumatic stress symptoms, and depression. And other common complaints that clients usually report or bring into for online therapy sessions, which are suitable for online therapy sessions, are issues around body image or weight, family relationships, other relationships at work or school at work, etc. And basically, there are definitely more areas that have started being treated or supported by online modalities, and more research is, it's an evolving area. So there is research which is going on. This is from the existing research that I'm sharing with regards to what kind of concerns or complaints can be brought into online therapy by clients. Next. And there is a large body of methodologically strong studies which demonstrate positive outcomes for even telephone delivered psychotherapy. And I mean, if you look at this, that most crisis helplines are telephone operated. So if you see, it always existed, right? All the crisis 24/7 helplines are telephone delivered. And much of this research was conducted by Moore, who concluded that enough positive trials exist for telephone CBT to be considered an empirically supported treatment. There is evidence pointing to, again, what we've discussed earlier, the possible cost saving of this particular format. And also studies on clinical and administrative outcome reveal that those treated with distant methods have a higher attendance rate, for a very valid reason, given it's cost effective, given you can access it from the comfort of wherever you feel safe and comfortable. So there is lower attrition of the clients also. So providers are happy that they're able to retain their patients better when it's a blended format, or patients have an opportunity or option to connect with their providers using the online modalities. Next. Yeah. So guidelines differ from standards in that standards are mandatory and may be accompanied by an enforcement mechanism. Guidelines are an aspirational, they are aspirational in intent that this is what could be ideal. This is what we may already be following in-person world, and we must try and follow it in the online mental health space as well when we provide therapy. And most of these guidelines have been amalgamated. What I'm going to share is amalgamated from what has been followed by the APA, the American Telemedicine Association, NIMHANS, British Association of Counseling Psychologists, and of my own experiences of setting up remote tele-psychotherapy platforms in an Indian setting. And we can follow these guidelines till we develop well-researched standards of practice. And I think those are, again, evolving and in progress as we speak. And guidelines for assessment informed by all of these agencies that I shared can really help in our own setting as well, because we are still working on them, and more research has happened in those settings already. It has been in prevalence for almost 6 decades in a certain country, and we can always borrow these and try and implement these and see if they are culturally fit for us, on what modifications then we do need to make for our own settings. Next. Yeah, and again, the assessment guidelines are sourced from the APA. And, so current scenario, it really poses a huge challenge with, specifically if we speak of the recent times of the pandemic, things may have improved now. We are back in our clinics again. But there was a time when it was a huge challenge to do assessments and follow the standardized procedures that we follow in in-person settings, which could have kind of prevented people from seeking the right kind of care pathways, or people could be bringing in crisis, but there was no way to assess at that point in time. And that's when these guidelines were created. So basically, follow the same ethics for testing. So do not jeopardize test security. That's the basic principle. Follow the same ethics for testing as one would follow in in-person settings. If stimulus material is developed for in-person testing, try not to click pictures of it and or send material to the client via some other ways, because it makes a difference when you administer. So we'll have to be mindful of what kind of tests and screenings are we using. Can a paper pencil screening be something we can do together in a session? But doing a battery which requires physical stimulation of things may not be possible, of course. And one can try to monitor test administration remotely using audio-visual aids. So it could be at a remote setup where maybe there is another provider or a lesser trained person who can administer these tests with your instructions, and you can observe how it is happening. Is something which was tried during the pandemic by a lot of clinicians. Potential difficulties can be when conducting psychological assessment via telehealth, and it should be discussed explicitly. The experience may be different, the scores could be impacted, the test behavior could be impacted. So again, then we come to principle 3, that be rigorously mindful of the data quality. It is not going to be the same as you would receive probably when you're doing it in person. And we may not be able to just depend on one test that we have conducted. We may need, anyways, we say that we should always conduct a battery of tests or screenings which can be supported by some other tests to come at a particular conclusion. I think it is important to be very mindful about the data quality that we may be receiving. Also, there are screenings and tests which may take a lot of time. And in physical, just like you give them breaks in your in-person settings, you could give them similar breaks, or schedule it in 2 different sessions. And since there is a paucity of research for equivalence of testing in remote online format as compared to the traditional format, one should use one's knowledge of processes that underlie or are driving performance on tasks, right? And then assess how these processes can get affected by online administration. Again, like I'm talking about the test behavior, the motivation to take a test on an online screen, or how are those things impacting the entire test performance and even your own administration. We may have to practice quite a bit before we actually bring a screening to a particular client. And for example, pure verbal tasks may not get impacted, but non-verbal tasks may get impacted. And then another important thing to consider is something which I said earlier, that don't be dependent on a single test score to guide your clinical decisions. No single test score should ever make a clinical decision. Include the margin of error, the context of the individual, and the other factors which may be impacting the assessment, scores, the performance, etc. And continue to integrate the test data with the other sources of qualitative data that we may get from their relatives, their caregivers, and from the case history. And only then we should come to a conclusion inclusive of the screening results that we see. And it is important to again contextualize it for our own settings, these guidelines, and it can help to seek supervision from people who've been doing it or who have some experience, and for anything where there is a doubt. And yeah, I mean, it's basically saying that it can be overwhelming initially, and it is best when it is done with either peer supervision or with supervision from people you trust and have been seeking supervision from. Next. Yes, and now what I'm going to share with you are some guidelines which are drawn from a review article which examined and synthesized guidelines to guide mental health professionals to deliver mental health care in an ethically and legally safe way. And these had a particular focus on video conferencing, and a total of 19 guidelines from renowned countries and regions, US, UK, Australia, certain countries in Asia. All of these were taken, and then they arrived at these particular recommendations, if I can say, to bring it into your practice to ensure that you are doing your best, bringing in all the controls, taking care of what whatever you're offering is legally and ethically safe. And the first thing is appropriateness of the e-mental health service that you're offering. And the first step to before deciding to consider a client suitable for online modality is very important. What are the concerns they are bringing in? If they are if they're in extreme crisis, if they are suffering from a concern which impacts their ability to use devices, which impacts their cognitive abilities, then is this modality going to be suitable for them or not? So usually everybody agrees, most guidelines say that if the first session could be in person, then it's the best to make this kind of an assessment about whether this service is going to be appropriate for the client who has approached you and is considering online therapy because of various barriers they have. But if that's not possible, you could still follow the process that's shared here to ensure that you are doing that assessment very thoroughly to say whether you can support this particular client who has come to you via online modalities. For example, if a client is bringing in phobia or extreme anxiety about something, can graded exposure be offered on chat or on video, and what kind of risks would there be as compared to when you have offered it in person as well? There are no exact guidelines even now or standards around now as to how we adopt or adapt these various psychotherapies we deliver in-person session onto online. And it's only with practice and brainstorming, like how we are doing right now, can we arrive at what can we offer as therapies, what is the appropriate psychotherapy modality that I can bring in, what is the school of thought I can bring in, what is the client's condition, what is the context. So that is a very important point, appropriateness of the service. Consider the capacity of the patient to arrange for practical and technological necessities. They don't have devices, they have poor internet, then definitely they're not a good candidate for this. Yeah, we can go to the next one. Yeah, and type of service. So be aware that psychological testing assessments are designed for in-person implementation, may not be possible. We've kind of done this in the previous thing, but if you're planning to offer psychodiagnostics, then you be aware that the psychological testing or assessment should be designed in a way that can be delivered online. And there are many available now that can be offered in an online way as well. Next. So what are some legal, again, there are some more points I think I would like to share before we go on to the legal and ethical issues. It is important to conduct relevant research for the choice of psychotherapy techniques that you're wanting to deliver. Then just as in in-person sessions, telepsychology providers may want to enhance their own skills with regards to being culturally competent to deliver online services to different populations. Language could be a barrier. What is their own literacy about therapy? What kind of awareness you may need to do even before you start offering actual sessions where therapeutic work may be conducted. So you may need to spend some time, couple of sessions before you start therapy work, to build the alliance, to help them get accustomed to the modality that you are wanting to offer therapy with them. And informed consent is something we'll talk about later, which is really important, whether you plan to do assessment, whether you plan to do group sessions, whether you plan to do individual sessions. And informed consent is nothing but telling everything very transparently about the risks, the benefits, your own qualifications, what are you trained in, what has your experience been like, and also letting them know that if there is crisis, this is how you could support, and this is what you could not, these are things which you cannot support with. So the person, when they are coming in and opting in for it, we know that they are informed. It doesn't reduces the liability on us to actually provide support when they may bring in crisis, even when they have, even when they joined, they may not be in a situation which was a crisis situation. So there will have to be some discussions around safety plan as well, right? And when we talk of informed consent, legal and ethical issues need to be discussed, which are around lack of awareness of location of the client. A lot of people are offering therapy to clients based outside of India, and this question comes up a lot in these trainings around should we do it, should we not do it, what are the things you have to keep in mind. And we know they are an Indian client. They may be of Indian origin, but they may be a resident of that country. So which law would apply if something goes wrong? So this kind of awareness is really important to be able to offer online therapy with confidence. We can answer that question later. Misuse of computer applications, privacy concerns. What is the platform I am using? Like I said, when I started with Skype, I realized it may be recording. Am I using WhatsApp? Is it safe for the user? If there are chats between you and your client, who can access those chats? Is the client aware of it, that the chats can be accessed and misused, say in relationship or divorce cases? Their conversations could be misused. Is the client aware of that? How can you help them receive these services in a safe manner? That's also something that falls onto our responsibility list of responsibilities. Serious concerns regarding issues of informed consent, duty of care. So if you get to know a child is experiencing sexual abuse, or the person comes in with suicidal thoughts, there are many countries where there is a compulsory duty of care, where we need to inform about these incidences. How do we follow that? How are we going to manage that? And ethical and legal challenges, of course, as confidentiality and data security as well. There are many apps. We have an app called Visa, and this is something that we solved for before we launched the app, that the data that the client is sharing, which could be very intimate data, which would carry a lot of personally identifiable details, which if remain on the system can actually, and if there's a data breach, if that data gets stolen, those identities could be exposed. You can actually join the pieces. In some conversations, they will talk about their husband, the workplace. Sometimes they will put in some other things like their state of residence. And all of this string together can expose their identity, make them vulnerable to other kind of risks as well. So how do you ensure that everything, just saying that everything is confidential between you and me is one thing, because you're not going to talk about your client. Of course, we all follow those ethical principles, but then the software, the platform that you're using, where is the data being stored? How are they going to use that data? So go and read how Zoom uses the data that is being shared. And that is the reason why they specifically created Zoom for healthcare. They had to create Zoom for healthcare because we realize that healthcare provision, whether it's mental health care, physical health care, is making people talk about their health conditions. And as a third-party software, some pieces, bits and pieces, pockets of data may be getting stored on Zoom server, which is a third-party server. And as a provider, I have, if I have no other issues, if I have no other access to any other safer platform, then this will be discussed in informed consent, that this is a third-party software. And I will try to ensure as much confidentiality. I will try and redact the data in chat conversations, or we will delete it, or we will not talk about this in chat, and we will only discuss this when we are on an audio call or a video call, or some decisions you may have to take. Next. Do we want to take a break? I hope it's not too overwhelming or not a lot of information overload. Varshini and Dr. Kirti?
We can continue, I think.
Yeah, and okay, and yeah, and then legal and regulatory steps, which we are, I think, stringently following, trying to follow in our own country of residences, our registration and accreditation steps. For MPhils, we know we need to go and register with the RCI. Then we need to know and comply with the relevant laws and regulations, like we have the POCSO, the Mental Health Act, the Data Privacy Act. We need to be familiar. We don't need to know them in depth, but we need to be familiar with regards to what is it. For example, POCSO will require us to inform or alert the caregivers, the guardians, and maybe also the police in case if we get to know of sexual abuse happening in case of a minor. And the Data Privacy Act will help you know what are the kind of platforms to use, what kind of receipts, or what is the informed consent guide, the wordings that I will use properly, and be aware of the legislative differences across jurisdictions. So in India, we don't have any concerns right now that I'm sitting in Delhi and I see a client in Bangalore, but in a country like US, there are a professional sitting in one state cannot see a client in the other state. They have relaxed these rules during the pandemic, but as we return back to in-person practices, they may revert back to how it was earlier. So we need to know what does say if I have a client who is a citizen of US, not somebody from India visiting there, what are they entitled to in terms of privacy, in terms of confidentiality, and if there's a breach, then it is possible that they can file or sue the provider in their own country, or they can even file or put up a case here, but they are a resident, so some amount of laws of the land for them will also apply, and that can create a lot of trouble. Ensure licensing board approves online services and check relevant credential requirements. For example, RCI's definition of a clinical psychologist, how Mental Health Act defines various professional streams that we have for mental health. Next. Record keeping and electronic records. Adhere to the usual laws and professional standards as in face-to-face services. So just like you maintain the clinical notes, you will be maintaining those notes for your online practice as well. Ensure that you store the data in a way which maintains the privacy of your client. For example, on Visa, when we are making clinical notes, and also in the chat conversations when we are offering chat-based therapy, we after the conversation is over, we will redact all the PII, or the personally identifiable information, or PHI, personal health information that client may have mentioned. So name of medications, name of the condition, any addresses, any workplace address or location, all these are considered PII, and they need to be redacted if you're storing this data specifically online, because on the internet it is more vulnerable that a data breach can happen. For clinical notes, you can use keywords for your own self. For example, the client came in with low mood, then saying depression, but you know it's depression, right? And you can say they are in their 40s but not mention the exact age. So that's you're putting the notes there, and you're ensuring that it is not completely revealing of the identity of the client. And again, informed consent for this cannot be emphasized enough, that you need to let the client know that either you'll be maintaining offline notes or online notes. And NIMHANS guidelines have a sample session recording form also to refer, an informed consent form to refer to. Next. Discuss how do we bring in confidentiality or privacy during the session. Discuss security risks with clients in the form of documented consent. As usual practice require, the user needs to be identified or identifiable. Some people in some countries need to give in their driving licenses or some form of identifying document to verify that they are who they are when they're coming into the session, so they don't breach confidentiality of the actual user. Take steps to verify the client's caregiver's identity wherever necessary, ensuring confidentiality in usage and storage of the electronic material. So if they are sharing their Aadhaar card or something with you as proof of who they are for their identity, how are you storing it? Where are you storing it? Are you seeing it and deleting it immediately? Then there can be guidelines. For example, we follow the ISO standards for this, and and we have defined that we can store data, some essential data that we need for 8 years or 10 years. And then when we say this, we also have to keep in mind what are the controls I'm implementing to ensure that the stored data is safe. It is on G Drive, a backup is being taken, checks are being maintained around who accesses the document. For example, when you came into Zoom, there was an ID given. So am I just sharing a Zoom link without any ID requirements? A Zoom link which can be just clicked and joined. So all these things will ensure the confidentiality and privacy during the session. Yeah, next. Questions to ponder on how will you proceed when privacy is invaded from either therapist or client side. For example, I'm sitting with a screen there and there's also a wall actually where I'm sitting. So chances of somebody walking in from the back and intruding into the sessions are lesser. Similarly, for the client side, you need to talk to them and let them know how they can maintain their safety, sit in a room where you are by yourself, you're comfortable, and check with them, is there a possibility of someone being present around you? For a lot of individuals who experience trauma, abuse, it's possible that their perpetrators could be around them. Then it is difficult for them to have conversations. And in that time, you can actually, can you use code words with them? So with my clients, we actually agree on code words like red. So if, or something else, it could be, and they can just utter that word and it will alert me that someone is around and we need to pause, or we need to switch to text based modalities. Right? Sorry. Okay, next. Informed consent we've discussed in detail. I think you can skip this. Also, NIMAN's guidelines, if you download, you will see a sample informed consent in there. Yeah, we can skip this. And you'll get the slides, so don't worry. Something to keep in mind are competencies for online therapy or counseling. General professional competence as a psychologist, of course, then provide online services within the boundaries of the competence. If I'm a clinical psychologist, what are the things I can support my client with? What are some things where I need to signpost? Can I prescribe medication? If not, I'll need to signpost them to a psychiatrist. Similarly, as a counseling psychologist, can I do psychodiagnostics? Can I offer psychotherapy for somebody who's experiencing psychotic symptoms, and will somebody with psychotic symptoms, active hallucinations, be a actual suitable client for online therapies? Again, what is your professional competence say about that? Assist clients in evaluating these competencies. They may have questions and we should transparently answer them that this is who I am, this is what I can offer, and this is how I can assist you with your concerns you're bringing in. There are a lot of therapy speak happening on Instagram, right? What do you think of that, where people who are not therapists are talking about openly about mental health concerns, sharing tips and strategies? That's also the use of online modality. And even though it may help benefit with creating awareness, it will also reach to a wrong kind of assistance being provided to these clients. That technical competence, of course, we need to acquire requisite skills to deliver, manage technological aspects of the service. What device, what platform, and if it's online therapy, how should my sitting placement look like? How can I make it friendly? How can I make it a calm atmosphere? How do I interpret silences and pauses while I'm offering text-based therapy, right? There could be a long gap. What do I say in that gap? So those are things which can be very well addressed when there is when you are trained for it. So some competencies will need to be built, and training is possible for those kind of specific scenarios where modality is a specific modality. Yeah. Next. Client suitability, I think we discussed earlier when we were talking about appropriateness. Next. Yeah, we can skip this as well. I'm sorry, I think the time is a bit less, and hence I'm skipping the slides. For pointers, we have already discussed. Intake session, yeah, that NIMHANS guidelines were there. Then how do we maintain professional boundaries? I think this is a very important point in the online world. Your clients will find you on LinkedIn, they'll find you on Facebook, they'll find you on Twitter, wherever. And it is very important to be able to maintain those boundaries while using online modalities and online media. Maintain some level of professional language across all media as would be appropriate in person. So I may have a separate professional page for me on Facebook or on Instagram and may connect with clients there because I'm sharing mental health tips, strategies about my webinars there, but not give them access to my personal pages or allow them to come there. It can also be triggering and create clinical safety risks when people see their therapists who they haven't met in person in a very different way in their personal life. You're giving them full some amount of disclosure which is not intentional. It is not guarded, and so it's best to protect your own privacy and as well not bring in clients into that space, and be aware of posting any personal information online. There are scenarios where people have seen their therapist drinking or smoking, and that has impacted therapeutic alliance because the therapist has been working on addiction issues with them, and the trust got really affected because of how they really entered into the personal space of the therapist on the social media and saw all of that. Next. So again, it's the same thing. Is it ethical for me to Google my client if a client has come in and I go and search up their name? How ethical is that? What if I find out information about my client that is clinically significant, but they haven't shared that with me as yet? Will I breach the confidentiality? Is that confidentiality breach? And again, like the one we discussed, how do I handle clients' friend requests on Facebook or follows on Twitter? Next. Therapeutic alliance, again, we've discussed in detail. I'll just briefly sum it up that it is the same kind of efforts that you will put in in-person therapy to ensure client trusts you. And when you follow all of the other things that we have said initially, for example, a very warmly written but also transparent, informed consent, ensuring there is continuity in care. For example, you could allow for some amount of messaging or texting in between sessions, specifically if you're not seeing them in person. So that really helps in building the therapeutic alliance. The client feels cared for, but also maintain boundaries around the timings that they can message you only till a certain time or you will be not responding. So you set expectation. Expectation setting is super important for therapeutic alliance, specific or good therapeutic alliance, specifically on online modalities, because the boundaries are a little blurred over here. They feel that, oh, it's a WhatsApp number or it's this platform and I can just log in and I can just send in messages and I will receive a response. So for example, on Visa, we say the therapist will respond to you in 24 to 48 hours. So they know they've sent a response, they will not receive something within 24 to 48 hours, but they do then receive a response in 24 to 48 hours. So the trust is maintained. The kind of questions you ask, are you giving them enough holding space? So that is your professional competence as a psychologist, which is also really helpful in building therapeutic alliance. Yeah, next. And there are enough studies which show that when all of this is done, rapport, trust, comfort of patient is taken into concern. A good therapeutic alliance can be built online. In fact, at Visa, we've done studies where we've tried and implemented these guidelines into the conversations delivered via the artificial intelligence chatbot that we've created. And the therapeutic alliance that the chatbot, between the chatbot and the person using it, was as good as built between two human beings, the therapist and the client. So definitely we've seen and brought in these guidelines into a space which was not even led by a human, but of course manned and written by human therapists. And we saw that therapeutic alliance can be built online when we bring in these steps. Yeah, next. And most important thing is, how are we going to manage the crisis and distress management for clients online? One is, of course, it really helps that in the intake session or in the first session itself, you help develop some sort of a safety plan with your client. You may be doing this in person as well. If not, I think it's a very good idea to discuss scenarios where they may feel in crisis. How have they managed crisis in the past? Is there history of suicidal thoughts, self-harm? Is there a history of trauma abuse, or is there ongoing trauma abuse? And then we talk about safety plans. We help them identify in-person support for their geographical location, have relevant emergency phone numbers on hand for each session. Because you don't know, the client may just I mean, they may log into a session feeling overwhelmed and in crisis. And so all of this information you would have already got in the first session itself, that who can I call when you are in crisis and who do you trust? And if risk emerges, remain engaged with the client as you would in an in-person session, and obtain as many details as possible. And then, of course, signpost them if they need to helplines as well. Next. Yeah, we've, I think, discussed this. Next. We can, I think, just quickly cover this. I think I can extend for another 5 minutes if everybody's okay to be here for 5 more minutes. Preparing your client for shift. So this is for those scenarios where clients, it was basically for the pandemic as well. But now when you are planning to set up a blended model service where you want to spend some hours in person, some hours online, or go completely online, then talk about this to your client. Let them know how you're still competent enough to deliver the services they were receiving in person, online as well. Help the client with developing their technical competencies if they are not competent enough to receive the services online. Again, informed consent elements, discuss privacy and data privacy guidelines, and re-educate regarding your legal limitations, document the educational session and topics discussed. So summaries and regular documentation will also be super helpful in building not just the rapport, but also helping your client know that they are receiving everything as a keepsake for themselves as well. Yeah, next. Yeah, we've discussed the emergency plans that we need to build. Okay, and this is something which I just put in the slide for people who may plan to use telephone to offer psychotherapy. And like I said earlier, there is enough research by Moore that says that telephone delivered psychotherapy is very impactful. And there's a list of challenges here, like lack of control over environment, privacy confidentiality, therapeutic alliance, psychotherapist adjustment to telephone therapy, and what we can do, like set boundaries, require privacy. It's a repetition of the content we talked about earlier. Say for addressing crisis situations, exclude patients who are actively suicidal at intake, or exclude patients who are actively delusional or hallucinating at that point in time. And I still always feel that there's still something we can always do for such clients as well, where if it's possible to get in their caregivers, because they also need active support when they have relatives who are feeling actively suicidal or are actively hallucinating. Then it's the families that we can work with and help them take care of their clients better and guide them, at least, not feel like, okay, we arranged for a session, but there was no help. So there's always some help that we can offer because of our professional competencies and our knowledge about the in-person support that they can receive in their own geographical locations. Yeah, sorry, it's just exact heat. I'm sorry if it was rushed up. We could actually break these up into smaller pieces if a detailed discussion is needed later. But yeah, any questions are welcome.
Good evening, ma'am. Can I put one? It's nice to hear from you about this. Is actually not the in-depth communication that we have with the clients, particularly the conversation. I was looking for that. But any since I've been counseling students and I have come across with a scenario where from a physical interaction we went to an online conversation, and I had difficulty communicating because face to face it is a much more convenience that I had came along with, but then conversation of over online was bit reluctance and all that I faced.
All
Is
right.
there any, yeah, so how's the switch and how to take it on? That's like one of my query because I had faced it practically. That's why. Thank you.
Okay, and sorry, and were the barriers more from your side or from the client side?
No, from the client side. I was open for conversation, but since the face-to-face conversation had been quite a dominant feature in my counseling sessions. So when we switched to this online mode, the reluctance actually, and then finally, that conversation faded.
I see.
So, yeah.
Yeah. So I think what really helps, and I think it's a great question, and because the title was do's and don'ts, we stuck more to do's and don'ts, and like I said, we could have a different conversation around actual sessions. But I think what really helps is when you prepare the client really well, and they need a lot of reassurance that your presence will be as it was in the in-person sessions, and that I know you well, we are familiar with each other, and at this point we are embarking, our goals won't change, and this is how we will progress with the goals. So it does take some time. Also, a lot of individuals consider talking on telephone or talking on Zoom or Skype as something which is lighter or less intense, right, than the actual session where the setup is such. So I think how you create your setup is also very important. And we tested, like we have this background for Visa sessions that we have, when we were just doing it with setups that revealed too much about our own environment, where you're sitting your own personal space. That's also sometimes overwhelming for the client, or it can make them feel that you will not be hearing them enough. How are you maintaining eye contact? How often are you maintaining eye contact? Are you busy writing notes, and is that impacting the session? So there are very small nuances about how things will change from in person to online, to make the client feel assured that you are not taking it lightly, and your presence is the same as it was in person. And you can always prepare them that if I'm looking down, it doesn't mean that I'm not listening to you, I may be taking notes. And that is what happens when I say that you prepare the client for the shift. So you tell them what may appear different and what will remain the same. And if it is appearing different, it is simply because of the modality that's changing. The person, the relationship remains the same.
Thank you, ma'am. Useful advice. And moreover, the switch is because of Corona, and it was the first timer we went online.
Yes. So I think that is very valid.
Yes, yes.
Very valid.
I could make
Because
out, yeah.
both the provider and the client, for both of them, it's the first time, and that can definitely cause a lot of reluctance.
Thank you, ma'am. Thank you so much for your information.
If you can take a couple of minutes of your time, we have a couple of
Sure.
questions in the chat as well.
Sure.
So we have a question. It says, can we use screening tools such as perceived stress scales or others online? And how will it be beneficial?
Yeah, so see, usually, again, like I said, there are no specific guidelines on each of these tests or screenings, right? So either we develop it in a way where we give it to the client and and there are screenings available where you can just click the dot, just tick in the box kind of a thing. And you can do that live in the session. We do PHQ and GAD-7 screenings in a similar way in our sessions where they can check box. So we can create versions that can be delivered online. It's best done in your presence, as you would do in an in-person setting, where if they have any concerns or questions about certain items, you can answer them, help them understand. So they're also confident that my provider is here. And I think screenings definitely can be done. The other tests, like I said, which require more of performance or more in-depth say Rorschach, TAT, etc. Those I personally have no experience of doing it, and neither I have read any research supporting that such techniques can be done online.
Thank you, ma'am. So the next question is that when we see patients from a different country, but they are still of Indian origin, what guidelines do we follow? I mean, which place of residence, like what ethical issues, what guidelines do we follow there?
It's a big gray area. Our own laws are not developed enough to address it. But if they're of Indian origin and are traveling briefly, and if you've seen them in person initially, that is the safest, because then you are maintaining continuity in care. You know the client, you know where they are from, and then you're continuing to offer therapy when they're traveling. If they are a citizen of another country, they still take therapy because therapy is very expensive in the US, and also wait lines are huge and very long. They may prefer somebody from India because of the context, the similarity. They believe that you may understand them better than an US white therapist. Okay, so the color, the race, everything matters. Then again, the informed consent has to be framed in such a way where you discuss the risks associated with it. You let them know that these are the risks. What happens, like I said, what happens when there'll be a crisis? I will not be able to assist you. There's a huge time zone difference. So ideally, what I recommend is that you kind of spell it out very clearly in the informed consent. Encourage them to have an in-person therapist, even if it means seeing them once a month in the other geography, and then you provide more of a supportive therapy than intense psychotherapy or high intensity psychotherapy. Also, again, client suitability will be a good point to consider. What concerns are they bringing in? Relationship issues, work issues, things which can be dealt with, which don't have the propensity to trigger a clinical risk. So your first 1 or 2 sessions, the screenings that you're doing, your own competence to gauge the client suitability will be of extreme super importance here. If you take people who have serious mental health illnesses or are at risk of developing such concerns, then we are entering into a dangerous domain where liability on us increases. So also have a malpractice insurance for yourself.
Thank you, ma'am. We have one last question. What is an online platform that you would highly recommend it for counselors for tele?
So ideally, if you're seeing clients in just India alone, you don't need to. We didn't talk about 2 things which are HIPAA compliance and GDPR compliance, which are two compliance guidelines which are considered gold standard. And you will see a lot of Indian platforms also claiming that they are HIPAA compliance. When they are HIPAA compliance means they have all privacy metrics checkbox. So the data is not being transferred anywhere else. It's being stored on their own server, and the client has the right on the data. For example, on Visa, if a client clicks reset data, all the data is deleted. We don't store the data. The first right is the client's right on their data. So are they following those HIPAA guidelines? Exactly. So that's, if you find a platform which, like Zoom for healthcare, is HIPAA compliant, it's a safe platform. Now, in India, there are many companies which have, I am not remembering names right now, but I can share names later, who have come up with platforms which are HIPAA compliant. Even if they're not HIPAA compliant, at least they keep in mind the Data Protection Act that our own government has set up. And they have space where you can keep your clinical records. They have ways in which you can share that data with a third. Say, for example, you want your client's data to be shared with a psychiatrist. The client says that I need this data because I want to show my session records to my psychiatrist. So everything gets stored there in a safe manner. And so basic things to keep in mind is when you are thinking of a platform, ask what are the privacy guidelines where they are storing their data. Are they selling their data? Like, don't use your Facebook chats and conversations for therapy. So you get requests. I get a lot of requests saying that, can we have a session? I'll just call you on Facebook call. But it's completely non-safe in that sense. There is no data privacy. WhatsApp has now taken steps where you have specific pins for your own chats as well, right? So this is an additional layer. So they are making it safer for similar reasons, because there are a lot of professionals who have these conversations on WhatsApps as well. But it's still not the safest. So look for platforms which say they are HIPAA compliant, or which comply with the Data Protection Act India. I'll share some names later. I know there are people who have developed very good platforms here in India. They are larger telemedicine platforms, but mental health is also something that can be delivered via those platforms.
Thank you, ma'am. And we'll be passing it on to the participants as well.
Yes, I'll email and you can share that information with them.
Thank you.
Janani, you're very right. When we say exclude a suicidal client, doesn't mean you don't talk to them at all. It means you handhold them, you engage them, and you let them know of the limitations that your presence via online modalities can impact their the kind of support they wish to receive. So you're still there with them. It's not so we have clients who didn't come in suicidal, right? But then I wake up one morning, I enter my session, and the client is texting me that I am about to do this to myself. So it can happen in any point in time, not just during intake. We will handhold them. We will provide them all the guidance we can. We will bring in all our crisis management skills into the session. And at the same time, also let them know that what is the next best thing for them to do. They can continue to speak with you, but also it is best if they also have somebody around them. They visit an emergency, they go and see a psychiatrist or any in-person provider. It could be their doctor also, that they can seek support from.
All right. I think we are coming to the end of the session, and thank you so much, Smriti, for staying beyond 8, and it's already 8:15 here, and it's so precious time is there. So thank you so much for spending time and clarifying and explaining the processes and things to keep in mind. I think a lot of us have already shifted, but it's good to know that what are our limitations and boundaries and do's and don'ts. And so there are always some doubts. Can I do this? Is it okay or not? Many things I think were answered here in your session. So thank you so much and for answering the questions. I would like to thank Dr. Kirti also for inviting you over. And thank you, Varshini, and the team here. Abram, everybody is here. Shafi, Snehas, I think the whole team is here. Mahima, sir, I saw. So I think if it's okay, can I request everyone to switch on their camera so we take a screenshot and for our social media. If you don't want, we can always not switch on your camera. So it's just to put up in our Instagram and Facebook page that we had a session. So just Varshini, you're taking screenshots, or I will take. Yeah, there are 2 pages. Yeah. Yeah, a lot have not actually, but it's still okay. Now we are having, yeah, okay. All right. Okay. So thank you, participants. Everybody was here by 7. And what's surprising is everybody is still here, though it is 7:15. Nobody is left. So that means, Smriti, you have kept them engaged, and everybody was looking forward to your talk also.
Yeah, thank you. Thank you. I think that's really, I'm really grateful that it's a Saturday evening and people are still here. So yeah, thank you. And if needed, we could always have a follow-up as well, because I know this is not enough.
Yeah. Maybe like how Dr. Vidya was asking about certain challenges that we may face in the
Maybe we
process.
should just have a AMA kind of a thing, maybe just do question answer rounds as well.
Right,
That's also
right.
something we could do. But I
Yeah.
enjoyed this, so thank you for having me. And yeah, I think it's been a wonderful evening for me. So thank you.
Thank you. Thank you so much. Thank you, everyone.
Thank you,
We'll
Smriti.
end the
Wonderful, wonderful listening to you, and as always. And we are all definitely looking forward to posting you again.
Yes,
Thank you
all
so
right.
much.
Yeah, bye-bye.
Thank you.
Bye.